aliquot, which is the okay, I'll start with the first aliquot, which is the chief complaint. And I have a 56-year-old Asian female who presents with a small left periauricular erythematous lesion. So she has a small lesion on her left ear, around the ear.
All right, let's pause there and pontificate together, because do I have a left ear lesion schema? I do not, but we can make one together. So whenever I think about a lesion that is new, a couple of like characteristics that would be helpful. One is like, how long has it been there and how the patient has noticed it, right? Is it painful? Is it itchy? Did I just saw it in the mirror and noticed it? And then the other characteristic that I'm looking at is like kind of how we describe rashes, right? Is it like ulcerated? Is it scaled over? Is it localized, or is it diffuse? Before I even like jump into differentials, then you kind of always like want to help define the problem. So that it would be the first thing that I would want to do. And the other thing is like thinking about the ear, is that if there was any trauma or anything like that as well. So those are the initial thought that comes to my mind. Jack, anything to add?
No, I think I am in the same boat as you in terms of not necessarily having an organized approach to this. I think another thing that I end up thinking about whenever there's something that can that can seem somewhat non-specific to start, is rather than focusing on the thing that is non-specific, like a possible skin lesion, is to look for the company that skin lesion keeps, or the company that symptom overall keeps. Because I think if I think about things that can involve the ear, there can be very focal cutaneous syndromes like the ones that you mentioned, but then there's also lots of other things, or rarer but potentially more systemic diseases that can potentially have the ear as one of the places that ultimately it impacts. And so I think as we move forward in this, I think I'm going to be looking for, is this a disease process that is centering on only this one periauricular lesion? Or is the periauricular lesion one component of a much larger systemic syndrome that potentially involves things like the skin and other organ systems? Because that idea of, are we dealing with just this one thing, or is there actually a whole systemic syndrome that is coming alongside this this starting point here, can be a helpful way to move maybe into more comfortable problem spaces for us, but also at least organize, like, where do we really direct our focus? Is it just on this single lesion, or is it on a more broader systemic syndrome with this one lesion being a part of that process?
Then I'll start with the history of present illness. On that day when she presented with the left ear to the dermatologist, it was a small, painless periauricular erythematous lesion. And she had a previous complaint which was similar to this one. It was a lesion similar at her right ear. And the initial treatment by the same dermatologist back then was treatment with doxycycline, but no improvement. The right ear lesion was then reevaluated with a punched biopsy. The dermatologist prescribed hydrocortisone cream 2.5%. The lesion at the right ear disappeared. Then 1 month later, that's now, the patient developed the left oral edema or lesion edema, and it was again treated with hydrocortisone. And the lesion, one more time after this visit, disappeared. Then the patient returned to the dermatologist again about a month later with her right ear pinna to develop warmth and swelling, but no pain. Again, the similar lesion. And this time she returned to the physician because her hydrocortisone cream did not work anymore. I could continue with the review of systems, if you like. That would give us a little bit of a clue. Basically, All her review of system was unremarkable. She only admits to mild dry mouth and dry eyes, for which she occasionally uses eye drops when needed. Patient also admits, probably from a previous injury, right shoulder pain. And patient denies everything else like fevers, chills, fatigue, weight changes, hair loss, uveitis or redness in her eye. She denies hearing loss, tinnitus. She also denies abdominal pain, no nausea, vomiting, no blood in stool. And she doesn't have any morning stiffness when asked about that, or something like Raynaud's disease, where she has some tingling in her fingers after cold. That's about aliquot number 2. The next one would be past medical history.
Awesome. Thank you so much, Haz. This is a really, really rich case. Just to make sure, did you say that she does have Raynaud's phenomenon or she doesn't have Raynaud's
No,
phenomenon?
she doesn't. She only has
doesn't.
occasional dry eyes and dry mouth.
Okay. So I will say, I think if we were just to look at how this has evolved from the initial syndrome that we had, which was a single lesion, we have 2 other components of this, which is those 2 new components being that this is a disease process that is now expanding in space, and it's a disease process that is expanding in time. In terms of the space component, we see that there is now both that this process that we're seeing on the left ear also previously happened on the right ear, and it was steroid responsive in some capacity. I find that many things on the skin can be steroid responsive, and so that is not necessarily the most useful diagnostic tool. But the fact that this is something that has extended in time, I think, is helpful here. The reason for that is that it gives us a clue into some of the potential things that could cause inflammation of this ear structure, right? If we were to just use our general inflammatory framework of there is pain, swelling, and redness on the ear, to me, I'm translating that and saying that this is somebody who has had multiple episodes of an inflamed ear. And though that inflammatory framework is the same thing, whether it's in the lungs, in the GI tract, or on the skin. So we could think about infections, malignancies, autoimmune diseases as sort of the big 3 here. There's been multiple great comments in the chat about possible cancers that could do this, and many of the dermatologic cancers are a possibility here, whether that's something like a squamous cell carcinoma or a basal cell carcinoma or something like a melanoma. The fact that it's erythematous and relapsing maybe makes a malignancy a little bit less likely, because we usually expect cancers, once they're present, to be present and then continue to progress rather than to come and go. Infections can certainly do this, right? Cellulitis, whether that is otitis externa or auricular cellulitis, or various skin conditions of the sort of follicles and the pores of the face, which kind of come right up against the ear, they can all potentially cause lesions that come and go like this. I had very bad acne as a teenager, and I certainly had red, painful lesions that came up and would then go away in and around my face. And then I think the other very interesting, but certainly more or less common hypothesis to entertain here is possible autoimmune diseases. And I see some comments already in the chat as well about the possibility of things like periauricular chondritis or inflammation of the ear structures, which can be associated with some rheumatologic diseases like relapsing polychondritis and other vasculitides. And so I think that's one that I'm keeping in the back of my mind right now, not necessarily bringing it to the forefront, because we don't have maybe the strongest case for this being just a pure chondritis, or in other words, inflammation of the cartilage. But I think that's one thing to hold in the back of our head, realizing that something like folliculitis, cellulitis, or other sort of inflammatory or infectious skin conditions are probably much more likely. But as this case evolves, we may see that something like a chondritis becomes more and more at the center of the fold. Charmaine, what are your thoughts here?
Oh, I totally agree. I agree with you on that awesome reasoning process. And yeah, I think just like adding on the review of the symptoms, the mild dry mouth and eye, I think the question is like that is noise or a signal. And I think if we think about it as a signal, is that a signal towards also other immune diseases? I saw Sjogren's being mentioned as well. And, with Sjogren's, you can either be primary or it can be associated with other ones like lupus, dermatomyositis, and other ones that potentially can have rashes associated with it. So I think, yeah, the differential is like wide open as of now. So I'm excited to hear more.
Yes, then I'll continue with the next aliquot, which is the past medical history. And I would also do the physical exam. The past medical history include unremarkable, basically. It's hypolipidemia. She also has seasonal allergies. And in the past, there was a lumbar laminectomy about 9 years ago. Medications, only simvastatin for her hypercholesterolemia, loratadine for seasonal allergies, and the most recent one, hydrocortisone cream. Family history is unremarkable. There is nobody in the family who had anything like this before. Social history is unremarkable, married and works as a secretary, denies alcohol, tobacco, or illicit drugs. The physical exam is mainly unremarkable. The vitals are all within normal range. General, she's in no distress. She's good looking and everything is fine there. HEENT, and there we can see this time her edema and redness around the cartilage and periauricular area of her right ear or left ear. Normal cartilage on the other ear this time is normal, no signs of erythema or rash. No alopecia was seen, no malar rash, no oral ulcers, or tonsillar or pharyngeal congestion. Musculoskeletal was unremarkable except for a limited range of motion for internal rotation only of her right shoulder. Pulmonary, cardiac, and extremities are within normal range. I could continue with the first set of labs if you like.
Maybe we can just pause here and quickly comment on it, Hans, and then we can move towards the labs. Thank you so much. It's such an interesting case, stretching my clinical reasoning, which I love these exercises for. So I think in terms of like the past medical history and meds, there's like nothing that jumps out to me. The things that are always, I've said this, I think a million times, when I see the meds, I'm like, okay, what are we doing? What are the potential side effects of it? But nothing comes to my mind that would present like this. And I think in terms of like exposures, again, like, I agree with Jack that the nature of it, the relapsing doesn't quite sound like an infection. I don't see any exposures there as well. In terms of the exam, it's actually quite helpful, even though all of the abnormalities might just be in the ear. But again, if you're entertaining, as Jack was talking through with us during the first aliquot, if this is just a sign of a systemic process, then is there anything else that we can pick up? Are there any other lesions? I love the thoughtful exam about like looking at skin very thoroughly, the joint exams to see if there's any other signals that we can pick up here. And the only thing that we pick up is potential limited range of motion and the shoulder. So the question is like, is that connected, or is that an old injury, or something that the patients have had for a while? Jack, anything else that's jumping out to you?
No, I think, I guess I would say that I feel like where the exam helps us, exactly as you said, is really the fact that we can now say that there is sort of this auricular inflammation, which I think I am translating to auricular chondritis just based off of the description, the fact that it's in and around the cartilage. And I think there's sort of the three big categories that we talked about still hold, right? People can have infectious auricular chondritis, which is usually, if you're dealing with actual chondritis itself, less common infections. So things like fungal infections, maybe atypical mycobacterial infections like tuberculosis, and then syphilis can also get in there. And then and then also malignancies. And those malignancies can be things like lymphoma or something called leukemia cutis that can also come up. So if we say like, okay, those are the infections and the malignancies that can do it, the autoimmune diseases that can do it are usually a component of a broader systemic syndrome. And I'm really struck by the fact that we really don't have other clinical exam manifestations that would be associated with rheumatologic disease. So I'm also tempted, or I shouldn't say tempted, but I'm also struck by the absence of other things that could come with, for example, diseases like a vasculitis or something like relapsing polychondritis, where we may see things like nasal cartilage destruction. For example, people with RPC can have things like a saddle nose deformity. We don't see things like purpura or other findings of vasculitis, or I should say other cutaneous manifestations of a vasculitis on exam. And then we don't see things in the small joints of the hand or of the lower extremity. So we don't see findings of an inflammatory polyarthritis. And so I think if we're saying like, okay, there could be an isolated process of the auricular cartilage of which infections like syphilis, mycobacterial infections, or fungi are possible, or a malignancy of the cutaneous structures in and around the ear cartilage, that seems more likely here because we don't see the other company that a systemic autoimmune disease would usually bring with it based off of the exam. But other organ manifestations of vasculitides can oftentimes come up on things like labs, chest x-ray, or just the clinical progression of the case.
Yeah, I love that, Jack. I love that thinking. And I wonder, just layering on the steroid response, I think the question is like with the steroid response, was it just, they were not related to each other, right? Like that relapsing remitting is like the natural progression of the disease and the steroid had nothing to do with it? Or is it actually like steroid responsive? A lot of the time, like, with if I remember correctly, for the relapsing like polychondritis, it's usually systemic steroids. So I don't know if a topical one would be enough to have any effect, or like something like lymphoma, we often think about them as like steroid responsive, but is the dosage of like just a cream enough to induce any changes? So I think other things like infection that maybe is a little less likely here, but yeah, we'll have to see.
Okay, then I will continue with the labs. Hello?
Absolutely, Hans. Thank you.
So the complete blood count and liver enzymes were all normal. So in particular, the WBC was 3.8 times 10 high 9. Then the HB was 13.7 and HCT 42. Liver enzymes AST 45 and ALT 63. I don't have an alk-phos. And inflammatory markers were done as well. And here we have an ESR of 33, which is elevated. I think the range is 0 to 30. And a CRP of 2.9. And yes, the normal range is less than 10, so that is still within normal range. And I would stop here before I go into further lab.
Hans, maybe for the sake of time, maybe we can move forward with some other labs. I know you mentioned that there's a biopsy result coming, and I just want to make sure that we leave plenty of time for all of the rich data that you have.
Sure, then I'll continue. Based on her ESR, further serology was ordered. One was Anna, which was positive. It was 1 to 2,560. Negative would be less than 1 to 80, so it was positive. She had a positive rheumatoid factor. And I don't have the exact value, but they also did an anti-Rho SSA, which was positive, an anti-LA SSB, which was positive, complement C3 and C4 normal. All the other specialized tests like ribosomal P antibody negative, double-stranded DNA negative, anti-Smith antibody negative, and topoisomerase 1 antibody SCL70 negative. So we can summarize, we had a positive ANA, positive rheumatoid factor, positive SSA, and positive SSB.
All right. Well, I will say there are multiple different pathways to interpret this here. One of them is to say that, and I think that the more overwhelming one is to say, okay, now that we have ANA positivity and the fact that we also have sub-serology titers, right? So ANA oftentimes is used as a screening test to evaluate for the possibility of an underlying connective tissue disease, most commonly lupus, but there's a number of other ANA positive diseases out there, including things like Sjogren's syndrome, as well as things like mixed connective tissue disease, scleroderma, or systemic sclerosis. And so that is sort of a screening test here, and that's positive. But many individuals who don't have underlying connective tissue disease can still have a positive ANA. So there's two things that we have to then look to here, which is to say, okay, is there a clinical syndrome here that's compatible with a possible connective tissue disease? And then also, are there sub serologic titers that also map onto the clinical manifestation? So we're almost taking two pieces of the puzzle here now that we have the positive ANA. One piece of the puzzle is does the clinical syndrome that the patient in front of us has map onto a known connective tissue disease? And then do their sub serologies, things like the rheumatoid factor here, the SSA and the SSB, do those further support or refute that hypothesis of whatever that connective tissue disease is? For example, a positive ANA, a positive double-stranded DNA in the setting of cytopenias and glomerulonephritis looks a lot like lupus, and then those sub-serologic titers would support that hypothesis. So here we have the positive ANA, the positive rheumatoid factor, and then the positive SSA and SSB antibodies, which all paint a serologic picture of Sjogren's syndrome. But I think that then the question that we have to ask is, does the clinical manifestations or does the illness script of the patient in front of us map onto our illness script of Sjogren's syndrome? And I'll turn it over to Charmaine to take us through that part of it, because I think Sjogren's is one, for me at least, that I probably have some of the least familiarity with in terms of never actually seeing a case of it in real life, but only having read about it.
All right. I 100% am with you. And I think like the hard part with people with autoimmune disease is like some of the serological also overlaps, like anti-Ro and anti-LA, like SSA, SSB, sometimes like with rashes of like lupus, it can also become positive. So I feel like there is just like so much like overlap. So as Jack perfectly summarizes, like we really want to make sure it matches the clinical syndromes, and that's why we often get help from our rheumatologist. In terms of like whether this is compatible with Sjogren's or not, I think when I think about like Sjogren's, I think about the mucosal involvement. So if I'm thinking about the clinical features of a Sjogren's disease, I think about mucosal, like ocular, oral, like vaginal involvement. And then there's also like some visceral organ findings that are less common, including like, lung in the form of like ILD. ASC, I believe, was like a little bit elevated. So sometimes like people can have like PBC involving the liver. Kidneys can sometimes be involved, and there's can be neurological, hematological involvement, but those are like often less likely. The one thing that I do not have in my illness script for Sjogren's is ear involvement, which I could totally be wrong about that. But one thing that is often happens with autoimmune diseases is they can be associated with other autoimmune diseases. And I think in this case, like, relapsing polychondritis is often associated with Sjogren's. And oftentimes, I wonder, like going back to that seasonal allergies, is that actually not seasonal allergies? Is it like chondritis that is presenting as seasonal? That was like maybe misdiagnosed as seasonal allergies because seasonal allergies are so much more common. So again, that I am making assumptions that might not be true, but thinking about how we can relate these things to each other. And the one thing that I was going to say, like one thing that was like quite helpful even before we got the serologic in this case, I often give ESR a hard time, but in this case is actually in someone that the exam is otherwise normal, like you don't really picking up anything information other than the ear, the fact that the ESR is quite high, it would make me intrigued to like, hey, is there any other systemic sign of inflammation going on? Is there any other autoimmune diseases going on? So I found this in this particular, before we got the subserologist, quite helpful, because you have to kind of explain why that ESR is elevated as well. Anything else, Jack, before we move on?
No, I think that was so well said, Sherman. I really love the analogous reasoning that you use there of like, I'm not familiar of the ear being a part of Sjogren's, which I'm not either, but being able to draw a line of like Sjogren's can present with a systemic vasculitis or a cutaneous vasculitis. And then that cutaneous vasculitis can sometimes be associated with things like polychondritis or auricular inflammation. And so if A to B to C is possible, then maybe just A to C is possible. I love the way that you walk through it. And I think it's such a good point here. The only other thing that popped into my mind was just the association between Sjogren's in and of itself and lymphoma. And I think given that we had talked about lymphoma as being one of the possible malignancies that can manifest with auricular inflammation, it was just one other line. But I think the line that you drew is much, much more likely here, which is to say that Sjogren's, that what we're seeing is a cutaneous manifestation involving the cartilage in the setting of Sjogren's. And I think the way that you supported that argument was just flawless. So I love it. Thank you for I learned a ton from hearing you walk through that. So that was awesome.
I always learn a ton from you, friend. Hans, teach us more.
Okay, I think I'll continue with the last aliquot, which is the biopsy. So a biopsy of the left periauricular lesion, which was affected, has been done, and it showed atypical lymphoid infiltrate in superficial and deep dermis with perivascular and adnexal involvement within the follicular epidermis. The overlying epidermis is largely uninvolved, and the pathologist has not seen any dermal mucin deposition. Subsequent immunohistochemistry, it showed CD3 positive infiltrate with significant skew of more CD4 than CD8 present within the follicular epithelium. Immunohistochemical staining was negative for CD20. It was negative for BCL6, negative for CD21, CD10, and PD1. The conclusion here was it is negative for chronic T-cell or B-cell lymphoma and T-cell receptor clonal rearrangements. So this immunohistochemical staining ruled out any possibility for a possible cutaneous T-cell lymphoma or malignancy in this direction. And this leaves us with a very small differential.
All right, Jack, do you want to talk through this together?
Oh, no, I was just going to say, I think that the small differential is the one diagnosis that you just brilliantly walked us through.
Take us home, friend.
Okay, the discussion. Yes, I can continue. The discussion.
Go ahead, Han.
The differential at that point was it a tumid lupus, which is a very rare case of lupus, remotely related to SLE. However, tumid lupus apparently comes with a significant dermal mucin deposition, so that was excluded as well. So the patient in all likelihood has no SLE or lupus-associated disease. Relapsing polychondritis is quite likely. However, the patient does not fulfill the criteria for relapsing polychondritis, which are the McAdams criteria. And the McAdams criteria include a bilateral auricular chondritis, non-erosive, seronegative inflammatory polyarthritis. It affects the nasal cartilages oral inflammation can be seen in most of all relapsing polyarthritis. Comes with antibodies against cartilage and eventual resolution of cartilage and disfigurement that the patient will experience over time. So it has to be treated seriously. This left us basically only with the manifestation of Sjögren's syndrome in the skin, a kind of cutaneous Sjögren syndrome. And that fits with her mild symptoms of dry mouth and dry eyes. So a cutaneous Sjögren syndrome.
Amazing. Hans, thank you so much for this case. I think this is I love all of your cases and really all of the cases that we get to think through on here. But I think some of the most valuable and the most educational cases are one where there is a very clear and sound path to the final diagnosis, and along the way there are so many other touch points that we get to explore together. And I think that this case that you brought here really exemplified that, right? Like we got to talk through ANA titers, Sjögren syndrome, auricular inflammation, ear lesions, the McAdam criteria, cutaneous findings that might be associated with a T-cell lymphoma. And so while there is one final diagnosis here, the full scope of what we got to explore together was incredibly rich and incredibly deep. And I just want to say thank you for bringing a case that allowed us to do that. If you are out here and say, gosh, I really want to do what Hans did for this case and bring a patient presentation that is fun to talk through and going to be incredibly educational for the people who get to join the people who decide to join the VMR space, then please do check out the Case Review Committee. It is a group of very enthusiastic VMR team members who are incredibly excited to help you put together a case. Because what Hans did, while he makes it look effortless and easy, can be made that effortless and that easy by having the support of a team to help prepare for it. So please do, if you're interested in presenting a case, reach out to the Case Review Committee. Because Hans, I just want to say thank you so much for putting this together. It was a real blast to learn from. I will pull up the email for the Case Review Committee so that those of you who may want to present a case can reach out and have whatever support you need to prepare it for presentation here. But Charmaine, any other final reflections on the case?
What a ride. Thank you so much, Hans, for presenting. Learned a ton. Cutaneous Sjögren syndrome. Whoa, need to read a lot more about that one. Really appreciate Noah for scribing, and Aisha, I think we're ready for you. Thank you so much for doing the teaching points.
Hi. Thank you so much for the case, Hans. That was very interesting. And thank you for discussing it. Okay, so today we have a 56-year-old female with no past medical history who presented with a painless erythematous earlobe rash. So when we're looking at a new lesion, what we need to consider, first of all, is to start off with how long has this rash been there? How did the patient notice it first? Did they see it in the mirror? Did someone else see it? Was it painful? Was it itchy? Did it irritate them? And then you need to figure out how to describe the rash. Is it localized or is it diffuse? Was there any trauma associated with it previously that they might have not noticed? And you have to think about a lot of systemic diseases that could also include the ear, or it could be an isolated periauricular. Is it an isolated lesion, or is it part of a greater condition, this is just a small part of it? So with these kinds of lesions, we have to think about it in they expand in time, space and time, which means that they may have previously occurred in another area on the body. So for this patient, it happened in the right ear, and then it happened in the left ear. So you have to consider, did it happen somewhere else? And how long has this been going on? Has this been expanding in time? Has it been going on for a long time? Was it acute? And when you think about some of the causes, some of the differentials, you have to look for differentials that could indicate inflammation. So look for pain, any swelling, any redness, which could signify multiple episodes which would signify that this could have been due to multiple episodes of inflammation. And possible etiologies that we were thinking about is either malignant causes like lymphomas or leukemias, or we can think about infectious causes, so auricular cellulitis or acne that might have spread from your face to your ears to your neck, and other possible autoimmune diseases which is usually rare, but it's still possible. So which could include lupus, Sjögren's, and periauricular chondritis, and other causes such as fungal infections and syphilis as well. And what we have to really pay attention and focus on is that when we have the labs, we might have the serologies, but we have to figure out if the clinical picture that the patient is presenting with, does it match the serologies that we found? So an example would be if the patient has a positive ANA, that is used as a screening tool for a lot of other connective tissue diseases such as lupus, Sjögren's, scleroderma, mixed connective tissue diseases. But when we have that finding, does it match the clinical picture? And that will guide us to find the final diagnosis. And another teaching point, don't underestimate the power of ESR, because it could be high, it could be low. It could, if it's high, it could indicate other autoimmune disease etiologies that we might have not thought about for the patient. And that's what I have.
Amazing. Thank you so much, Aisha. That was an incredible summary of a phenomenal case. I just want to say thanks everybody so much for coming out this morning. I'm going to briefly take over the screen just to plug the case review committee with some more information one more time here. Let me just make sure that I can do this. And give me 1 second. For those of you who need to log off, please again, feel free to do so. I unfortunately am on a new laptop, so I am not able to share right now because my Zoom is not configured for it, but I will put the email in the chat here really fast. If you have a case that you want to present, please do email the case review committee at theclinicalproblemsolvers@gmail.com. We would love to have you bring your case because every time that we get to learn from one of your cases, it is a huge gift to all of us. So Hans, thank you for giving us that gift today. And yeah, just want to say thanks again, everybody. We'll see you next time.